Good morning, everyone. Thank you for being here today in person and also virtually. It's my pleasure to welcome you to our session today. And I just thought I'd start with a few opening remarks, given the location of today's historic convening and how this institution, Howard University, is home to the 5th oldest dental school in the United States. In fact, according to the dean, Dr. Andrea Jackson, since 1881, which is 142 years, the College of Dentistry at Howard University has trained thousands of highly skilled health professionals in the field of dentistry and dental hygiene, which service particularly to underserved populations. So I'm truly honored to have the opportunity to moderate such a distinguished panel this morning. And our panel topic, or our panel title, is Oral Health Disparities Through the Lifespan, Challenges and Opportunities. My name is Shondelle Wilson-Frederick, and I just have a few more comments and I will hand it over to Dr. Chalmers to kick us off. So for today's panel, each of our 3 speakers will have 15 minutes or so to present, 15, 17 minutes. That will allow for us to hold some question and answer period of about 10 to 15 minutes at the conclusion of all 3 of their presentations. Also, the order of panel presentations will be Dr. Chalmers first, followed by Dr. Sheen, and then Dr. Shoff. And that ends my remarks, and I welcome Dr. Chalmers.
Good morning, one. It's such a pleasure to see you all in person and be with all of you. I think the remarks from this morning are so inspirational because they challenge us to think about what we can do to address any of the disparities we may hear about. And I hope you can take this as we talk about one of the most prevalent disparities, and that's disparities in oral health. I will start by sharing with you the vision and strategic pillars of CMS, because that truly guides everything we do in oral health and beyond. And that is to serve the public as a trusted partner and steward, dedicating to advancing health equity, expanding coverage, and improving health outcomes. And these are not in random order. Addressing health disparities, expanding coverage, and thinking about health outcomes. And oral health has a role to play in all of them. You see the pillars: advancing equity, expanding access, engaging with partners. This is why it's so important for us to work together. It will take all of us to address these disparities, thinking about innovative models, protecting our programs, and fostering excellence. I wanted to start by very quick level setting of the size of the program. And these are the January 2023 enrollment numbers. Over 93 million people are served by the Medicaid and CHIP program. Just to reflect on the scope and the impact we have across the US. As you can see, over 85 in Medicaid and 7 in CHIP. Yeah. And what is most important is to just read on the bottom where it says that 46% of the total enrollment these were the children, right? So it's really important to just reflect on that. But also to highlight another piece that not every state looks the same. You know, people always say, oh, it's Medicaid. But if it's Medicaid in that state, doesn't mean it's the same reality in another state. And even if you just look at the percentage of children and adults enrolled in Medicaid, look how different that map looks, right? In some states, it's somewhere between 15%, in other states, close to 40. So it's really important because that presents the landscape of some of the challenges and opportunities that we're going to talk about. And then also, when you think about the percentage of live births that are paid by Medicaid, and this is a little bit old, but it hasn't changed that much, an average about 40, but again, look at the huge geographic variation in each state. So again, when we talk about pregnancy and oral health, this is the landscape of where this impact happens. And if you look at who pays for the live births, this is truly important to recognize that For non-Hispanics, Blacks, Medicaid covers about 60% of births. So again, as we think about the disparities, it's truly important to recognize the landscape of each program. But here is where we are in oral health. And I want you to look at this graph and look at the very left side first, because this is where we have made dramatic progress in children's oral health. So on the top, you see the line that represents children who don't live in poverty. The green is the children who live in poverty. And you see that gap closing, right? That's great progress, but I would challenge all of us, are we okay with that gap staying that wide? Then you look at the adults in the middle, and what do you see? There has basically been no change at all for 20 years or so. And in seniors, the gap is actually widening. So seniors who don't live in poverty enjoy some of the best access to dental services in the delivery system compared to seniors in poverty. So we have huge opportunities. But related to pregnancy, the middle is where you want to focus on, because if you know, only about a quarter, less than a quarter of adults see a dentist, you know, the pregnant individuals will be only a subset of that. And I'll show you based on some recent analysis how minimum that is. But the other piece that's important to recognize is that these deep disparities in access to dental care persist both for children and adults. And what you see here, again, the gaps have closed, so they're not as wide, but for children, there's still about 13% racial disparity in access to dental services, and for adults, it's about 20. So overall, you saw it by poverty. Now you're looking at overall by race and ethnicity. And the other piece that's really important is so how in every state, the population varies of how many children and adults are enrolled in Medicaid. The other piece that varies dramatically is actually coverage. So adult Medicaid dental is an optional benefit, and states can have the flexibilities to cover a very limited number of services or very extended set of services. And what you see on the left is the variation in what states covered as of October of 22. The most wonderful thing is that math has been changing over the last few years, and states are recognizing the importance of oral health and adding more services. But I want you to pick, and maybe one good state is Maryland, because I mean, not very far from here. You see at that moment, October 22, Maryland didn't have an adult coverage for dental services, but they had a very good coverage for pregnant individuals. Again, recognizing at the policy level that although the state didn't cover everybody, they covered pregnant individuals because oral health is so important to the outcomes. And we all know the disparities that exist in maternal outcomes, and improving oral health is one way to get there. I realize this is probably very small for you to read, but there are multiple connections between poor oral health during pregnancy related to the health of the mom, but also related to the health of the baby. So you can imagine for moms, if they have inflammation that may drive some of the systemic inflammation, they can impact the baby. But also as part of pregnancy, we all know someone who's had morning sickness. So that also can impact oral health. So it goes both ways. And these are some of the conditions that you can see during pregnancy. So there, you know, if you can have an adult with severe dental caries, you may have something in that's very rare but occurs. It's only it's called pyogenic granuloma or pregnancy oral trauma. So that only happens during pregnancy. And if you don't have access to dental services, what do you do, right? Well, how do you address that? If you have periodontal disease or gingivitis, these are again very commonly known conditions that can happen during pregnancy. And the way these periodontal diseases or inflammation drive the connection with other outcomes is the recognition that you have these inflammatory comorbidities that are connected to the periodontal disease. So we may or may not know the exact mechanisms, but we know that people with poor periodontal disease have worse health outcomes. So very strong association. And for many of them, we actually know pretty well the biological drivers of that association and the causality. And pregnancy is actually one of them. We know the pathways, the bacteremia, the oropharyngeal, the orodigestive ways how bacteria can impact overall health. And I'll tell you a very interesting story, how actually the connection with preterm birth was established. I knew the researcher who was doing that work, and she was trying to develop a model for periodontal disease, this gum inflammation. And so she injected one of the very well-known periodontal bacteria to create this in a mouse. And all of the mice had spontaneous abortion. And they're like, oh, there must be a connection, right? A few years later, right, we actually know some of the drivers of that connection. And we understand that periodontal oral bacteria don't stay in the mouth. They have impact on the overall body, either by driving very severe inflammatory response or actually being disseminated to the site, to the placenta, etc. So just remember that as we think, oh, people like, what is the connection between oral health and overall health or maternal outcomes? And here is another really powerful study. This is from commercially insured moms. And they looked at an association of maternal periodontal disease and adverse pregnancy outcomes. And if you had periodontal disease, 10% higher odds of low birth weight, 15 of preterm birth, 34 of spontaneous abortion, overall about 20%. Now you think about a way to improve maternal outcomes that are so strong with potential single connection, which is the inflammation driven by the periodontal disease. You can look at the data and the slides, but let me get to the heart of the matter. Over the last year, we've worked with a currently developed measure by the Dental Quality Alliance to understand the utilization of dental services by pregnant individuals who had a live birth. And we looked at oral evaluation. So did you go to a dentist? Did you have an exam? Or any dental service, meaning did you go to the dentist for any reason? So you will see that the yellow bars that are any dental service are always higher, because chances are maybe it wasn't an exam, maybe it was for treatment or other needs. But what do you notice? Overall, less than 10% of women who had live birth in the Medicaid programs had a dental visit. And more importantly, look at the difference between age. If you're under 20, all states cover dental services because they're considered children in the program. Look at the higher rates of utilization. Compare after 20, when you're now an adult and you may or live in a state that has the dental services or not, right? So that's a really important thing. And then again, to just highlight the huge geographic variation. In some states, less than 3%. In other states, around 20%. And other states, very well, over close to 36. So it's important to recognize the national trends, but also appreciate how different that looks at the state level. And we ask further, if you had a live birth and you had an oral evaluation or any dental services, were there any differences based on race and ethnicity? And you can see here, again, all the yellow bars, meaning any dental service are higher, but you can appreciate the significant disparities that exist. To me, putting forward yet another question of how do we solve for this? How do we connect pregnant moms to providers? And what may be the barriers, right? What are the barriers? Is it finding the dentist? Is it the understanding of what the connection is? Or is it something else, transportation? We know that there's so many barriers when it comes to finding a dental provider. And when you look at that based on their primary language, English, other, and Spanish, it looks somewhat similar. Here, just a note that the data is not complete, meaning we only could look at where this data existed when the language was recorded. And then if we think about the dental services utilization based on rural versus urban, of note, just the rural communities face additional burdens of getting to a provider. I think not just dentists, any provider where we know that's a challenge. And again, you can see any dental service, meaning you were able to get to a dentist to address the need. So if we were to conclude, as of October, we actually celebrated last October a huge milestone. For the first time in the history of the Medicaid program, every state offered something to pregnant individuals from dental services. And I want to be very clear, it's not the same coverage, meaning the benefits still vary, but for the first time, every state in DC had something, which is great. Now I think we need to get to the next level is to, help make that connection between maternal outcomes, oral health, and drive that synergy forward. Overall, there's very low utilization, so huge room for improvement. Ideally, we would want to be in the 50s, the 60s percentile. And in that specific time for pregnant moms, why not try to see as many as possible? If they have a prenatal visit, why not have the same level and care and standard for dental visit? Because the impact is the same. If your high blood pressure can drive poor outcomes, your periodontal disease can drive poor outcomes. And it's really putting it at the same level. Same. And then there are significant utilization differences when you look at it by age. Again, clearly recognizing that when you consider the child under 20, that service is covered. So you have access to a dentist, less barriers. And when you're an adult, depending on the state where you live, you may or may not have access, providing additional barriers and challenges. And I think the last piece to think about is that they are, when you think about, there are no significant racial disparities, urban versus rural, and primary language. So again, just to recognize that maybe perhaps this is one of the areas where we have somewhat of an equalizer as it comes to dental services for pregnant individuals. So I hope you walk out of this session with a clear appreciation of the connection of the mouth and the rest of the body throughout the lifespan, including this very special time when individuals are pregnant and deliver birth, and some of the challenges that remain that are very by state. And we have a long ways to go because 10% is pretty low. We should do better. We must do better because, the US has some of the worst maternal outcomes in the world. Oh, I think that's my timer. And I think we should use every strategy to improve these outcomes, including improving oral health and working together with our medical colleagues to elevate the importance of oral health, understand the barriers. And one piece that I didn't talk about, but if mom has good oral health during the pregnancy and the early months after birth, dental diseases are infection diseases. They transmit from the caregiver to the baby. So potentially by improving the mom's oral health, you're actually setting the child on a different trajectory. And we can talk a little bit more in the questions and answers, but I don't want us to forget that there is a long-term benefit of improving mom's oral health, and that is related to the health of the children. All right, I know we'll do questions in the end. And next, you have my contact. We'll turn it over to Dr. Sheen. Thank you.
Good morning, everybody. My name is Alex Sheen. I currently serve as a Pediatric Dentistry Policy Fellow in the Office of the Administrator, work with Dr. Chalmers and the rest of the team. Today, I'm going to be talking about the impact of COVID-19 pandemic on racial and ethnic disparities in dental rehabilitation under general anesthesia. So as Dr. Chalmers kind of mentioned, dental caries is a very common, the most common chronic disease that affects pediatric patients in the US. It is bacterial in nature, infectious, and affects all ages, from infants all the way to adolescents, as well as all demographic groups. You can see here in this figure from 2011 to 12, roughly 14% of children aged 2 to 8 had some sort of untreated tooth decay in their primary teeth. Also known as baby teeth. Now, important strides have been made in the last couple decades that has helped decrease the prevalence of dental caries in pediatric populations. For example, general access to care for many low-income children has improved as a result of Medicaid and CHIP reform. However, significant racial and social disparities still exist, with major gaps in access to care. Affordable dental care for many vulnerable populations remaining a prevalent problem. And when we look at the demographic breakdown here, we can see that tooth decay was significantly higher for both non-Hispanic Black populations at 21% and Hispanic populations at 19%, compared with their non-Hispanic white counterparts. And these trends have been consistent and persistent over the years. We can see even in 2013 to 14 NHANES data, three groups, American Indian, Alaskan Natives, Mexican Americans, and Black pediatric populations, all had higher prevalence of early childhood caries, with American Indian and Alaskan Native preschool children having the highest. Additionally, the NHANES data also showed that more than 43% of American Indian and Alaskan Native children between 3 to 5 years of age had untreated tooth decay, as compared to 10% for their non-Hispanic white counterparts, which is almost a fourfold difference. And in this graphic, we can see the differences in public health insurance coverage between different ages and different demographic groups. And notably in 2021, among children under the age of 19, 58.7% of Black, non-Hispanic children, as well as American Indian and Alaskan Native children held public coverage. Next followed by Hispanic children, which was at 53.7%. Those identifying as white, non-Hispanic, and Asian non-Hispanic had the lowest public coverage at 28.1% and 28% respectively. And these differences in coverage may reflect the differences in the income to poverty distribution of children under the ages of 19. Children in families with income at or above 400% are less likely to be eligible to receive coverage through Medicaid and CHIP, and children in demographic groups with the highest rates of public coverage tend to be from the lowest proportion of families that are above 400% of the poverty level. And from this graphic, you can see the three demographic groups that we had talked about make up about 47% of the Medicaid and CHIP beneficiaries. And so Medicaid and CHIP do play a very significant role in expanding access to care for many of the underserved populations, especially those that are of pediatric. So as we stated before, dental caries is the most common chronic disease in children. And here we can see a number of presentations of dental caries in children. And I think the most important thing to note here is the progressive nature of the disease, as well as how quickly it can progress. At its beginning stages, you can see on the far left, we can see areas of what we call demineralization, which are essentially just areas where cavitated lesions may begin to start. And in the absence of any sort of preventive services, the tooth structure, as you can see, progressively begins to deteriorate and degrade. The lesion increases in size, and eventually tooth structure begins to, we begin to lose tooth structure. As it progresses, bacteria eventually can infiltrate the pulpal tissues, which can cause dental pain, and eventually, without treatment, dental infection can manifest as a localized abscess, as extraoral swelling, and in some cases, more systemic complications. And so what's important to note here is that these are all preschool age children, which can kind of evidence at how quickly this disease can progress. The extent and nature of treatment, as you might expect, becomes more involved as the disease progresses. In its early stages, some lesions can be prevented or arrested, as we looked at on the top left. However, once the lesion becomes too severe and too extensive, oftentimes restorative and sometimes surgical treatment is necessary. As you can see in an example down below, on the most bottom right in its most severe form, these anterior primary teeth, so these front teeth, will most likely need to be extracted, and oftentimes there's going to be severe lesions in the posterior, which would often result, if not extractions, some sort of full coverage options such as stainless steel crowns and sometimes nerve treatment. And so why this is important to the discussion of health equity is that, as we've seen, there exists racial disparities in terms of untreated tooth decay and prevalence of early childhood caries that come from disparities with regards to access to oral health care. As a result, these populations tend to have dental disease that goes untreated and progresses more severely, often resulting in increased use of emergency departments and urgent care facilities that oftentimes really only can provide palliative care. And with many chronic conditions, dental caries and poor oral health has many impacts that span far beyond the oral cavity. Here we can see several examples. of its effects with children specifically. But dental caries and pain can often result in decreased food intake, lost weight from pain when consuming hot and cold beverages, or chewing and biting difficulties. It can result in sleep difficulties that results in behavior changes such as increased irritability and lower self-esteem. And oftentimes severe pain can result in missed school hours, which can result in poor academic performance. So the consequences of severe dental disease, as you can see, not only affect oral health, but can lead to decreases in multiple areas of quality of life for these children. And so the disease management plan for pediatric patients often considers two questions. It considers what type of treatment needs to be done and how do we provide that treatment safely for both the patient and the provider. The disease management plan is often based on a combination of factors such as the patient's age, their caries risk, their behavior, any immediate or acute needs, any presence of any infection or special healthcare needs. And some patients may be unable to tolerate treatment in a traditional dental setting with basic behavior management modalities. For example, a young pediatric patient may not have the developmental capacity to sit in the chair and stay still for a filling. And sometimes if the patient has extensive disease that requires multiple restorations and surgery, it may not be possible to safely complete all that work in a traditional dental chair. And so in many cases, these young children with the most severe disease who require multiple fillings, nerve treatments, extractions, oftentimes the safest option for treatment is under general anesthesia. And our analysis looked at dental rehabilitation that was performed under general anesthesia, which is oftentimes performed in a hospital outpatient dental setting or an ambulatory surgery center. So at its definition, general anesthesia is a controlled state of unconsciousness accompanied by a loss of protective reflexes, including the ability to maintain an airway independently and respond purposefully. And depending again on the patient, general anesthesia is typically administered in these two settings: hospital outpatient departments, ambulatory surgery centers. And as you can see from here, I know it's a lot of text, but the decision to perform dental treatment under general anesthesia balances many different factors, including the patient traits, extent of the treatment, other treatment options, emergent needs, and as we said, special healthcare needs. So the COVID-19 pandemic had an unprecedented effect on all aspects of healthcare delivery, including oral healthcare. However, to our knowledge, no studies or reports have been released regarding the pandemic's effects on dental rehabilitation under general anesthesia for pediatric patients. And so our analysis had two main questions and objectives. We sought to provide an overview just of the impact of the COVID-19 pandemic on access to dental rehabilitation in those two settings that we talked about, and as well as assessing how patient demographics influenced and utilization rates of dental rehabilitation procedures. And so for our analysis, we looked at 2019 to 2021 TMSIS analytical files. We looked at the different age, race, ethnicity, enrollment status, and the state of residence, and used the other services file to identify dental rehabilitation procedures and overall medical and dental service utilization. And our study focused on children ages 12 and under who were enrolled in Medicaid and CHIP. And this particular group was our focus just because these are generally the patients that need general anesthesia services. The dental rehabilitation procedures were identified using the HCPCS code 41899, and the place of service codes were used to identify where the procedure was completed. After using the Medicaid DQ analysis to observe any data quality concerns, our final analysis included 26 states in total. An important note about the limitations of the analysis is that the availability of data relied upon providers and health systems to consistently use the CPT code 41899, which requires kind of standardization of the Medicaid claims data across the state when coding for dental rehabilitation under general anesthesia. So states that consistently utilize the code were more represented in the analysis, which may limit the scope of national representation for our findings. However, with some states not being represented, our analysis may even be underestimating the impact of the COVID-19 pandemic on the states and different demographic groups. So here you can see the rates of dental rehabilitation that were performed either in a hospital outpatient department or an ambulatory surgery center for patients aged 0 to 12, organized by race and ethnicity. So you can see on the bottom, we have the different demographic groups from non-Hispanic white populations, non-Hispanic Black populations, And then you can see for each group, we have 3 rates. In the orange, we have rates from 2019, blue represent 2020, and the yellow represents 2021. So for example, if you look at non-Hispanic, Asian, Pacific populations, for example, you can see that in 2019, the rates per 10,000 were around 38. And then in 2020, as expected, when the COVID-19 pandemic occurred, the dental rehabilitation rates decreased to 24. And then in 2021, as recovery from the pandemic began, resumption of services occurred, we didn't really see any recovery in dental rehabilitation rates for this population group. So what's initially striking about our findings from this graphic are the overall higher rates of dental rehabilitation under general anesthesia for the American Indian, Alaskan Native pediatric populations over all 3 years by a pretty significant margin. And as these populations, as we saw, have traditionally experienced the highest rates of untreated dental decay and early childhood caries, these high rates of dental rehabilitation may reflect the severity and extent of caries within this population. And then I just wanted to take a second to zoom in a little so we can appreciate some of the trends that we observed with dental rehabilitation from 2019 to 2021. So here we have non-Hispanic white populations, Hispanic populations, and non-Hispanic Black populations. And we can see that during the year of the pandemic, we saw a decrease in the dental rehabilitation rates for all 3 populations, which is in line with the majority of surgical services based on existing reports. Where we begin to see differences amongst different demographic groups is in 2021. So we can see that for non-Hispanic whites, dental rehabilitation rates continue to decrease into 2021. Interestingly, and as you can see for Hispanic populations, that number recovered to almost pre-pandemic levels. Also, when we looked at the initial data, Hispanic and non-Hispanic Blacks with both fairly similar rates of untreated dental decay and prevalence of early childhood caries, you can see that the utilization rates of dental rehabilitation and general anesthesia for non-Hispanic Blacks was much lower, not only compared with their Hispanic counterparts, but also for their non-Hispanic white counterparts. And so it's a little beyond the scope of our analysis to really determine the rationale behind these, but it does, I think, raise certain questions. For example, are there certain barriers to accessing this type of care for one population and not the other? Are there cultural reasons that might explain, encourage or discourage use of a specific service? Moreover, the rate of dental rehabilitation, as we saw, recovered to almost pre-pandemic levels for Hispanic populations, but for their non-Hispanic white counterparts, we saw a decrease in those rates. And so is this again a cultural barrier to receiving care? And again, future studies and investigations may hopefully be able to provide more insight and rationale to these trends that we saw. And so dental rehabilitation under general anesthesia represents just but one tool in the toolkit for the dental disease management plan and the overarching oral healthcare system. But certainly, I think the differences that we saw in the utilization rates speak to some of the unique barriers and challenges that a lot of these demographics face. For example, about 2.4 million Native American populations live in counties designated as dental care shortage areas, with half of all Native American children living in a shortage area. We also see more than 2/3 of roads in many Indian reservations being dirt or gravel roads. And so this lack of access to very basic kind of preventive or restorative care may result in more severe and extensive disease that necessitates the use of general anesthesia to perform all that treatment. Another example, a cited issue for non-Hispanic Black children has been lack of or sporadic insurance coverage, which may hinder a patient's ability to receive dental rehabilitation under general anesthesia, which is often very expensive and costly. So as we think ahead to improving oral healthcare outcomes for vulnerable populations, what is clear is that oral health equity must be a part of that conversation. By recognizing the different needs that exist for each group, and understanding and tackling the different barriers to oral healthcare, whether that's systematic, administrative, or cultural, that each group both commonly and uniquely experiences, we can hopefully move closer to developing the appropriate interventions and processes to achieve overall improved and more equitable oral health outcomes that can lead to improved quality of life for all pediatric populations. My contact, thank you very much.
Good morning. My name is Carla Shoff, and I'm the Senior Advisor to the Chief Dental Officer at the Office of the Administrator at the Center for Medicare and Medicaid Services. It is a pleasure to be with you and share our recent work related to rural-urban disparities in dental opioid prescribing among adolescent, young adult, and adult Medicaid beneficiaries. Before we begin, I want to start with a very high-level overview of something you're very familiar with, which is the U.S. opioid epidemic. This should look very familiar to you. Here are the trends in opioid overdose deaths and the 3 waves of the opioid overdose deaths as described by the CDC. Wave 1 started in 1999, and it's the rise in the prescription opioid overdose deaths. Wave 2 started in 2010, and it is the rise in heroin overdose deaths. And Wave 3, the rise in synthetic opioid overdose deaths, started in 2013. Every day, 187 people die from an opioid overdose, and this is only exacerbated during the COVID-19 pandemic. One thing to note is that the trend for commonly prescribed opioids, as shown here in teal, hasn't really changed over this 20+ year time period. Another way to look at opioid epidemic is to think about total morphine milligram equivalents. This graphic shows that in 2011, we reached the height of billions of morphine milligram equivalents in the US market. There has been a steady and slow decline in total morphine milligram equivalents. What is not obvious here is who are the payers for these opioids. In 2011, opioids paid by commercial plans were the biggest proportion, followed by Medicare, Medicaid, and cash payers. Since then, there has been a steady decline. By 2019, there was a decrease in opioid prescriptions by commercial plans, cash payers, and Medicaid, but a slight increase paid by Medicare. In the next few slides, I will review the relevance of opioid prescribing to adolescents and young adults and the connection to dentistry. Dental providers are the second most common specialty group that prescribes opioids. They are second only to internal medicine, and this has remained true over the years. But more importantly, opioid-naive adolescents, these are patients who have never received an opioid prescription, often receive their first opioid prescription following a third molar extraction or another dental surgery. These patients are statistically more at risk for persistent opioid use and a subsequent diagnosis of opioid abuse. We have seen a decrease in opioid prescribing for Medicaid beneficiaries, but significant racial and ethnic disparities remain. Related to opioid-naive youth, it is important to recognize that in the 12 months following the initial opioid prescription, you can fall within 2 categories. 65% of patients fell within the high-risk trajectory group, shown in orange, and 13% of patients fell within the low-risk trajectory group, shown in black. How long do you think is the average amount of time the youth in the high-risk group received opioids? I would have thought 20 or 30 days for the high-risk group and maybe under 5 days for the low-risk group. But what this study actually shows is that the difference is actually very small. A 5-day average for the high-risk group and a 4-day average for the low-risk group. The results also show that the high-risk group had a median daily morphine milligram equivalent of 10 and 4.7 for the low-risk group. In addition to the risks associated with initial opioid prescription, we know that many of these youths and young adults face challenges accessing dental care. It can be especially challenging to access dental care in rural communities. In rural areas, there are low provider to population ratios, meaning the number of dentists compared to the population. Rural areas experience low number of dentists who accept Medicaid and CHIP or have discounted fee schedules. People living in rural communities may have insufficient lack of dental insurance, benefits, experience poverty, geographic barriers to care, lack of transportation, and lack of childcare. Some rural areas have insufficient levels of water fluoridation or have no water fluoridation at all. People living in rural areas have a lack of awareness and education about oral health, and there may be cultural barriers and stigma that may contribute to oral health disparities. Given all this, the objective of the this study were to assess the prevalence of dental opioid prescriptions among adolescent and young adults and adult Medicaid and CHIP beneficiaries who had a dental visit. To investigate the patient-related factors associated with an increased likelihood of receiving a dental opioid prescription, and to compare the differences in dental opioid prescribing patterns between rural and urban areas, and to identify if county-level factors contribute to these disparities. This study utilized multiple data sources, including the transformed Medicaid Statistical Information System analytic files. These files include data on enrollment, demographics, service utilization, and payments in Medicaid and Children's Health Insurance Program. Specifically, the demographic and eligibility, other services, and pharmacy files were utilized in the study. The data were accessed through the CMS Chronic Conditions Data Warehouse, also referred to as the CCW. This study includes Medicaid and CHIP adolescent and young adult beneficiaries ages 12 to 20 and adult beneficiaries ages 21 to 64. All beneficiaries included in the study are non-dually eligible for Medicare. The Economic Research Service Rural Urban Commuting Area codes were used to determine the rural urban status of the beneficiaries' residents. The U.S. Census Bureau's American Community Survey 5-year estimates were used to calculate the county characteristic measures. The CMS DQ Atlas was used to determine which states should be excluded from the analyses due to data quality concerns. States assigned as high concern or unusable on the following topics were excluded from all analyses: professional services claims volume, professional services procedure codes, prescription claims volume, and prescription national drug codes. Beneficiaries from 8 states were excluded from all analyses. Beneficiaries from states with high concern or unusable race and ethnicity data were excluded from all analyses stratified by race and ethnicity. Beneficiaries from 20 states are excluded due to race and ethnicity data quality concerns, 3 of which were already excluded for claims data quality concerns. So to be included in this study, beneficiaries must have had a dental visit in 2021. Beneficiaries are considered to have a dental visit if they had a billed claim with a CDT code for a dental procedure. This resulted in 6,659,544 adolescent and young adult beneficiaries and 5,755,792 adult beneficiaries included in all analyses that were not stratified by race and ethnicity. Chi-square tests were used to test for significant differences in the rates across categories within each group and to test whether the category-specific rates are significantly different across rural and urban areas. Multi-level logistic regression models were used to predict the odds of receiving a dental opioid prescription, and pooled t-tests were implemented to test whether the estimates are significantly different across the rural and urban models. I will start with the results for the adolescent and young adult beneficiaries. Here are the rates of receiving a dental opioid prescription per 1,000 adolescent and young adult beneficiaries by state. The rates vary across the state, with the lowest rate being 8 beneficiaries per 1,000 and the highest 90 beneficiaries per 1,000. States with the highest rates are generally located in the South and the Northwest. This bar chart represents the rates of adolescent and young adult beneficiaries receiving a dental opioid prescription by age. The rates are shown for overall, rural, and urban. Probably not surprisingly, the rates are higher among older age groups. Ages 12 to 14-year-olds, 7 beneficiaries per 1,000 received a dental opioid prescription compared to 43 beneficiaries for 15 to 17-year-olds, and 86 for 18 to 20-year-olds. This bar chart also shows significant disparities in the rates by age group across rural and urban areas. For example, among beneficiaries ages 18 to 20 years of age, the rate is 118 per 1,000 in rural areas versus 79 per 1,000 in urban areas. Chi-square tests were used to test for significant differences in the rates across categories within each group, such as the differences between the age group rates. Chi-square tests were also used to test whether the category-specific rates significantly differ across rural and urban areas. For example, is the rural age 18 to 20 rate significantly different from the urban age 18 to 20 rate? All rates are significantly different between the age groups, and the age-specific rates are significantly different across rural and urban areas. Here we examine the differences in the rates by sex. Adolescent and young adult female beneficiaries have significantly higher dental opioid prescription rates compared to male beneficiaries, and these rates are significantly different across rural and urban areas. Among female beneficiaries living in rural areas, the rate is 56 per 1,000 compared to 37 per 1,000 for the urban counterparts. Among male beneficiaries, the rate is 43 per 1,000 in rural areas and 30 per 1,000 in urban areas. Now we examine the difference in the rates of receiving a dental opioid prescription by race and ethnicity. Here we see statistically significant differences in the rates across all racial and ethnic groups. Looking at the rates overall, American Indian and Alaska Native beneficiaries have the highest rates at 59 beneficiaries per 1,000, followed by non-Hispanic white beneficiaries at 41 and multiracial and other race beneficiaries at 38. As you can see here, rural beneficiaries have higher rates than urban beneficiaries for every racial and ethnic group, except for American Indian and Alaska Native beneficiaries. The rates are equally high in rural and urban areas among American Indian and Alaska Native beneficiaries. In rural areas, the rates are highest among American Indian and Alaska Native beneficiaries at 57, followed by non-Hispanic Black beneficiaries at 54, and multiracial and other race beneficiaries at 51. In urban areas, the rates are highest among American Indian and Alaska Native beneficiaries, followed by non-Hispanic white beneficiaries and multiracial and other race beneficiaries. In the next few slides, I will show the results for adult beneficiaries. Among adult beneficiaries, the state level rates vary from 34 per 1,000 to 395 per 1,000. As we saw for adolescent and young adult beneficiaries, the states with the highest rates of beneficiaries receiving a dental opioid prescription are located in the South and in the Northwest. The relationship between age and the rate of beneficiaries receiving a dental opioid prescription is an inverted U shape. The rates among adolescent and young adult beneficiaries increase with each older age group, and among adult beneficiaries, the rates decrease with each older age group. The rates shown here are significantly different between age groups, and the age group specific rates are significantly different across rural and urban areas. Beneficiaries aged 21 to 34 who live in rural areas had the highest dental opioid prescription rates at 138 per 1,000 beneficiaries. Among adults in general and adults living in urban areas, the rates of receiving a dental opioid prescription are higher for females than males. However, among adults living in rural areas, the rates of receiving a dental opioid prescription are higher for males than they are for females. As was the case for adolescent and young adult beneficiaries have higher rates in rural areas than in urban areas for every racial and ethnic group except for American Indian and Alaska Native beneficiaries. The difference in the rates between rural and urban areas for American Indian and Alaska Native beneficiaries is not statistically significant. While American Indian and Alaska Native beneficiaries were the racial group with the highest rates of dental opioid prescription for adolescent and young adult beneficiaries, among adults, non-Hispanic Black beneficiaries have the highest rates, especially among those living in rural areas where the rate is 238 per 1,000 beneficiaries. Next, I will discuss the multivariate results. Before I dive into the results, I want to quickly walk through what these tables display. Here we show the results of the multi-level logistic regression models. The models include beneficiary characteristics in level 1 and county characteristics in level 2. The county FIPS code is included in the models as a level 2 random intercepts parameter to adjust for the similarity of beneficiaries residing within the same county. Separate multi-level logistic regression models were estimated for rural and urban beneficiaries. While multi-level logistic regression models are reported using odds ratios, I display the results here with the percentage change in the odds and the number of times more or less likely for ease of interpretation. This is what you see in the columns labeled rural model and urban model. All of the effects reported in these columns are statistically significant, except for the effects that are not shown and are instead displayed with NS for not statistically significant. In the t-test column, this shows whether the effect significantly differs across rural and urban models. If the effect is significantly different between the rural and urban models, it says SIG for statistically significant or NS for not statistically significant. This approach is the equivalent of a full interaction model. I will start with the results for the adolescent and young adult beneficiary models in the blue table. Compared to beneficiaries ages 12 to 14, beneficiaries aged 15 to 17 are 6.4 times more likely to receive a dental opioid prescription if they live in a rural area, and 7.4 times more likely if they live in an urban area. Beneficiaries 18 to 20 years old are 13.8 times more likely to receive a dental opioid prescription compared to beneficiaries ages 12 to 14 if they live in a rural area, and 16.7 times more likely if they live in an urban area. The odds of receiving a dental opioid prescription are 20% higher for females than they are for males among beneficiaries living in rural areas, and 16% higher for females compared to males among beneficiaries living in urban areas. Compared to non-Hispanic white beneficiaries, all racial and ethnic groups are significantly less likely to receive a dental opioid prescription, except for American Indian and Alaska Native beneficiaries, whose odds of receiving a dental opioid prescription are not significantly different from non-Hispanic whites. The effect for non-Hispanic Black beneficiaries is significantly different across rural and urban areas, with rural non-Hispanic Black beneficiaries being 7% less likely to receive a dental opioid prescription, and urban non-Hispanic Black beneficiaries being 11% less likely. As for the county characteristics, for every percentage point increase in the percentage of non-Hispanic Black residents, the odds of receiving a dental opioid prescription increased by 0.5 percentage point in rural areas. However, with every percentage point increase in the Hispanic population, the odds of receiving a dental opioid prescription decreased by 0.4% in rural areas and 1% in urban areas. With every unit increase in the concentrated disadvantage index, the odds of receiving a dental opioid prescription increased by 11% in rural areas and 18% in urban areas. In rural areas, adolescent and young adults who live in counties with more residential stability have 9% lower odds of receiving a dental opioid prescription. Now we will discuss the results for adult beneficiaries in the orange table. Compared to adults aged 21 to 34, older beneficiaries are significantly less likely to receive a dental opioid prescription. Adult female beneficiaries are less likely to receive a dental opioid prescription compared to males, and the odds are significantly lower for females living in rural areas than females living in urban areas. It is interesting to note that we found the opposite effect among adolescent and young adult beneficiaries. Among adults, we also find differences in the relationship between race and ethnicity and receiving a dental opioid prescription than we did for adolescent and young adults. Among adults, compared to non-Hispanic white beneficiaries, all racial and ethnic groups are significantly less likely to receive a dental opioid prescription, with one exception. Non-Hispanic Black beneficiaries are 10% more likely to receive a dental opioid prescription if they live in a rural area, and 18% more likely if they live in an urban area. As for the county characteristics, we find similar patterns as we did for adolescent and young adult beneficiaries. However, the effect of concentrated disadvantage is much stronger for adult beneficiaries. With every unit increase in the concentrated disadvantage index, the odds of receiving a dental opioid prescription increases by 23% among rural adults and 31% among urban adults. In summary, the rates of dental opioid prescriptions among adolescent and young adults are 36 and 96 per 1,000 Medicaid and CHIP beneficiaries with a dental visit. The patient-related factors have different effects on the odds of receiving a dental opioid prescription between adolescent and young adult beneficiaries with a dental visit. Significant rural and urban disparities exist in receiving a dental opioid prescription between adolescent and young adult beneficiaries with a dental visit. Thank you. Here's my contact information if you have any questions.
Thank you to all three of our presenters this morning. Those presentations were fantastic. And as a former CMSer, it was great to see the use and the presentation of TMSIS data. That, for those of you who may not know, it was a very heavy lift. on behalf of the department and the agency to do that and to see the quality of the data, being able to stratify by race, ethnicity, showing dental utilization and care for in maternal health, and then in adolescence, and then with opioid use. That was fantastic to see. We're open now for questions. Are there any online? Okay. That's a long question. So, in addressing, okay, yeah. I want to do justice to the question for our online community. Okay, thank you. In addressing barriers to care, has access to providers that accept Medicaid or CHIP been evaluated to improve utilization? And then there's a comment after the question. Given the difference in reimbursement rates between private and public insurance, many dental providers do not accept patients with public insurance. So even with coverage, patients cannot get dental care.
Well, I would like to thank the person who shared this question. Obviously, a very important question. And here are the facts. Nationally, about 43% of dentists participate in the Medicaid program. But as you saw me present the geographic variation in adult enrollment in Medicaid or births covered by Medicaid, that varies dramatically by states. Okay, we have states where close to 71% of dentists participate in the Medicaid program and others much lower. So again, we just have to understand that there is a great variation within the state. But even within a state, participation in the Medicaid program is only the first step, right? Patients need to get to the dentist. They need to have appointments available. Transportation needs to be available. So even in the states with the highest participation in accepting Medicaid, there's still challenges. And let me put yet another piece to this. Reimbursement rates are critical, right? For provider participations, but there are other barriers. And even in states with high reimbursement rates, we still have access to care challenges. So it's not a one solution that will address the access to care issues. As you heard, the disparities that exist between rural and urban are dramatic. And sometimes it's not that there is no dentist that accepts Medicaid, there's just no dentist in the rural communities, right? So driving to the emergency department may be a lot shorter than driving to actually finding a dentist who accepts the coverage. So I think that's a really important consideration, is that the density of dentists varies dramatically. As you heard, many of our beneficiaries live in areas that are designated, health professional shortage areas, specifically for dentists. And so that together with the low reimbursement rates presents a challenge. So it's a multifactorial piece, and the reimbursement rates clearly are part of that, but it's a lot more complex. So, and it has been evaluated. There are great papers out there. Happy to point the person to that, but and I would just say this is true for dental, but any other healthcare service, right? What we pay providers only can go so far, and it takes having the systems in place for them to be able to open their doors and for the patients to get to the dentist. So a very complex work. And yes. Any questions?
Any questions from the audience, those of you who are here in person, for the speakers?
And of course, this has only gotten worse. So the question was, what are some strategies that can help address the shortages? And provider burnout, healthcare shortages across the board in the healthcare system, and that has impacted the dental delivery system too. I think one piece to recognize is that it will take every provider, healthcare provider, and other providers, and I'll explain that in a minute, that touches our beneficiaries to address some of these challenges. The solution may not be in a brick and mortar dental clinic, right? We talked about how severely childhood caries touches children preschool, right? Okay, well, chances are they have had a well visit in a pediatrician's office, okay? This is where we need coordination and integration of care to tackle this problem very early on, because by the time they get to me, when they're 3 and they have 20 cavities, we are going to the operating room. A toddler is not going to tolerate 4 quadrants of dentistry to address all the disease. So it really starts by thinking where the early interventions and who are the providers that touch the child, and I would say the family, right? It's the caregivers, the mom, and thinking about these opportunities for coordination of care. Over the last a little bit over 2 years, we have worked with 13 states to improve access to preventive dental services in a non-dental setting. So pediatricians' offices, right? That's called the fluoride varnish affinity group. And we will be sharing at the end of the month on June 29th, there's a public webinar of sharing all of the learning. And as you can imagine, 13 states, that program looked very different, but we will share some success stories of innovative approaches to reach children early. What worked, what didn't, what were some of the barriers, right? Because it is important, and many of our colleagues recognize the need to address oral health, but if you don't have nurses to put the vaccinations, how do you have nurses to put the fluoride varnish, right? To your point about shortages. So it really comes down to priorities and integrating all of that work in the workflow of the clinic. It needs to work for everyone, right? And maybe I think for dental, one of the huge opportunities is to really think about the family, right? If the kids had an appointment, is there a way to see also mom? Then everybody is benefiting from that time. If mom needs to take time off work, and it's 3 hours, 1 hour there, 1 hour in the chair, 1 hour to go home. Can mom also get the care when the child is getting the care? I think this is the huge opportunity when it comes to dental, really thinking about the integration. There's some successful models where in the WIC clinic, right? You go and you get the women's and infant nutrition, right? You go and you talk about oral health. You get a toothbrush along with the additional well visits. So this will take a really, and we are, as I said, we work with states. We're in the process of defining the goals of the next 5 years in the oral health initiatives. And all of that is in the forefront. Like, how do we make sure that it's easiest for the beneficiary, right? So they have easiest access, but also for the providers who need to deliver the care. And what are the non-dental settings where you have opportunities to talk? Schools are actually an excellent place where healthcare services can be delivered, because mom and dad are not taking off work, kid is already there. And we know that, we are in the midst of a behavioral health crisis and the kid is already there. So again, all of these opportunities are there, and they include oral health, an evaluation, right? Are you in pain? Is this the source of the pain? What can we do? Can we make a referral? I think sometimes the challenge is if you identify the problem, what do you do? And you do need to find sometimes a dentist that can address these problems. But what a great question. It hasn't gotten easier. And I think this is where we need to be first very intentional about closing the disparity gaps, right? This needs to be a priority, and then finding the opportunity. Maybe it's in the community. Like, where are the children and the parents together where we have these opportunities to talk about oral health, inform, educate, deliver the best prevention is a toothbrush and a toothpaste. And I'll never forget, I was in clinic, grandma came, 2 hours on the bus, 3 grandchildren, beautiful, they're there a little bit late. We're like, we're going to see everybody, no worries. I'm doing the exam and talking about toothbrushing and toothpaste. And, the kids are saying, well, we brush when we're at grandma's. There is one toothbrush and we'll share it. To me, that's the challenge now, is to say, not only at grandma, also at home, each one has a new toothbrush every 3 months. That works. Actually that may seem like a very straightforward intervention, but it does work. And what are the barriers to that? Is it cost? Is it availability? Is it, remember, what are the barriers for us to understand that? And being very intentional, because I think there are plenty of kids who are getting access to dental care. It's like, where are the kids who are not, and what works with their family, with their caregivers, because sometimes it may or may not be the parents, right? So how do you support the caregiver to provide the access to dental services? But great question. And if you find a solution, please let me know, because we need it in dentistry. Yes. Absolutely. And that actually is very strong. And I wanted to address this when we talked about access to care, reimbursement rates. But this was also highlighted in the morning keynote, is actually being able to access a provider that looks like you has incredible impact on the health outcomes. And we simply don't have enough graduating dentists to address all the beneficiaries. But the data is very strong. It's a little complex, but let me just take time to explain it. Remember how I said in some states, 70% of providers are enrolled? But when you actually ask in the data, well, who actually sees someone? Like, did you see one patient this year? Or did you see 100 patients this year, right? That's very different. You enrolled, but did you actually see patients? And we know that our Black dentists see the most of our Black Medicaid beneficiaries. We know this, the data is very clear. So to your point, how do you intentionally increase the workforce that resembles the beneficiary as diversity? This is a difficult challenge because you can't fix that overnight, right? You need years, go to college, to go to dental school, but you can be intentional about it and say, what are the barriers? And in dentistry, cost of education is the #1 barrier. People are graduating with $250,000 in debt. And that, if you come from a disadvantaged background, you don't have the generational wealth to pay off the debt. You're paying $250,000 before you've even made a cent. So that drives some of the choices people make, understandably, right? Of where they live, where they work. But to me, again, being intentional, thinking about it, recognizing, institutions like Howard that can support training diverse workforce is one of the critical pathways to improving access to dental care. I know there was another question. Thank you. Yes. Yeah, very important. And one of the top priorities, not only in the Office of Minority Health, that has really systematically evaluated where the challenges are, where the gaps are, where there are gaps in collecting the data, where gaps in reporting the data. And one thing I would say for the Medicaid specifically data that we shared is reporting of race and ethnicity is not mandatory when you enroll in the program. So that's the first challenge, is you starting from -10, right? And we need to get to, +10. So that is one of the biggest challenges, but what I can assure you is the absolute commitment across the agency to get the highest quality data, the most reliable data. And when that's not possible, to use statistical weights, geocoding, there are methodologies in place to get as close as possible to the truth. And that's why you heard in both of our presentations that talked about race and ethnicity, we could only report it with certainty in about 20 some states, right? So recognizing the data limitations and focusing where you have the data. But I would say the data that comes to CMS is from the states. And Shondelle hinted at this, right? 8 years ago, 10 years ago, it was, okay, she's for those who can see, gently smiling because it was very difficult to work with that data. Cleaning up the data was half of the battle, right? Before you can actually run on us. So if you look at it historically, and I think this is important to just zoom out we have actually made incredible progress. To be able to tell these two stories on pregnancy, three stories, and OR access and opioids, we couldn't do this 4 years ago, 5 years, we couldn't do it. So to me, that progress needs to be acknowledged, and also understanding how states are struggling and finding them ways to support it. You know, I work with so many states, and I can tell you their data ability varies from a state who's like, I've got the dashboard stratified by everything, tell me what you want to know, to I can put a data request 6 months later, somebody can look at it, maybe they'll give me a report. Like, that is the landscape. And so the quality that comes with that, right? The reporting, the ability to check all the pieces varies dramatically. But, you know, really focusing on the bright spots and where we have good data. And to me, knowing the data, this granularity brings a lot of responsibility, because now you know the problem. You can't say we didn't know the problem, right? Before we could say we didn't know the problem, like truly we didn't. And what do we do now? You know, what are the initiatives? What are the interventions? How do you tackle that? What a great question. Yeah. Yes, please. Yeah. That's what a great question. So the question for the audience is, you know, what are some of the ways to share best practices when it comes to, you know, delivering oral health services outside of the dental delivery system and the dental office? So we have a few pathways how we can engage with states to make sure that all the initiatives that are related to oral health, everybody knows about what's working, what's not working. One of them is we are calling it the Oral Health Technical Advisory Groups. So we bring states every month on a call, and we share priority areas, challenges, emerging questions, you know, things that they're that are of interest to them. And we've had one on pregnancy and oral health. School-based programs is one of the areas where we want to identify success stories, school, you know, states where this works, highlighted at the call, and have the opportunity to share this with states. But the commitment at the agency level to school-based program is only evident in some of the recent guidance and waivers that we have given. So the state of Illinois is a great one. They came to us and said, look, to your point, the kids are already there. Is there anything we can do? And we said, there is. And these are the rules of doing this waiver. So we are very supportive. And I think since then, I want to say New Mexico and Oregon, but don't quote me this, 2 other states have come with school-based waivers to strengthen the school-based delivery system related to mental health. But as I said, this also is true for oral health services. And there are other organizations who either are part of the delivery of this services like mobile dentistry, right? Or FQHCs that bring the actual dental clinic to the school. So they are, but just have to remember it varies dramatically by state of what's allowed in what state. And we have that platform to share success stories at the state level. And it's so great. If you don't mind, what state was this? Is it Maryland? This is fantastic, right? This is fantastic. You see, in some states, actually, it's a requirement to have a screening prior entering kindergarten, like an oral health screening and a vision screening, and right? And so that becomes sort of, well, you can't even register for kindergarten if you didn't have a dental screening. Right? So there are many innovative ways that will take, again, partnering with the education system to make sure we address these issues. How are we doing on time? We are over time. Thank you for being here. You consider yourselves the oral health champions. We're so happy you were here. Thank you.